Welcome, everybody. Today I have Dr. Charles Matouk, who is Associate Professor of Neurosurgery, Vice Chair of Clinical Affairs, and Neurosurgery Chief of Interventional Neurosurgery with Yale University. And today we're going to delve into a relatively new hydrocephalus treatment currently in clinical trials using a device called an eShunt. Welcome, Dr. Matouk.
Well, thank you so much for having me, and it's a pleasure to be here, Diana, and it's a pleasure to be with you as part of the Hydrocephalus Association.
Wonderful. So let's get started. Tell us, what is the eShunt and how does it work?
Well, the eShunt is something that we're very excited about and represents, I think, one of the first new alternatives to a traditional ventricular shunt that we've seen since third ventriculostomy, which is, I guess, the last innovation that came along for the treatment and management of patients with hydrocephalus. What I think makes this device particularly unique is that it's all done from the inside out. And so you don't have to cut any skin, you don't have to drill a hole in anyone's skull, and you can treat the hydrocephalus from the inside in a very minimally invasive, we call it endovascular way, which is through the blood vessels. And so we can access a vein in somebody's groin area, and then use catheter technology and X-ray machines to find our way up to the base of the skull, where we can create essentially what's called a fistula, or a communication between a CSF pocket at the base of the skull and the top of the internal jugular vein, which is a large vein in your neck, which carries blood back to your heart. And so it allows essentially an alternative route for CSF to get out of the head, which is what a ventricular peritoneal shunt or a third ventriculostomy would do, but is done in this minimally invasive endovascular way. And the device, the little device that holds that communication open between the CSF pocket and the blood
Mhm.
space in your neck, that is what we call an eShunt. And it's literally a little sliver of plastic about the size of a fingernail trimming. And so it's very small, very unlikely to get infected, unlikely to cause over shunting, which are major problems that we see with, the standard shunts that we put in every day.
Wow, that is amazing. And certainly there's a lot of buzz in the hydrocephalus community and in the medical community about this. People want to know what it is and they're excited to see it coming. So I happen to know that you were involved in the first in human surgery in the United States using this e-shunt surgery. So what's the significance of that? There were surgeries before in other countries, I think in South America. Um,
That's right.
but doing
Yeah.
the first one in the US, tell us about why that's important.
It's a well, so it is that is the case. The first procedure, the first in human procedure was done in Buenos Aires, which is in Argentina, by a physician named Pedro Lilic, who's a prominent neurovascular proceduralist in our space. And we were very excited to be chosen to be the first program to place an eShunt in the United States at Yale New Haven Hospital back in 2022. And that has to do with the fact that we have expertise not only in hydrocephalus, but also in these interventional techniques that are used to deploy the device safely. So we were tremendously honored to be able to do that. The US is still, with everything going on at the moment in this country, we shouldn't lose sight of the fact that we really are the standard bearer for the rest of the world. And the FDA in particular, once a device is approved by the FDA, not only do we know that it's gone through this very rigorous process that meets very high standards for a device to be used here in the US, but many different agencies around the world, I think, lean heavily on the expertise and rigor of the FDA. And so that first in human case done in the US was the first step in that process, was building a case that this is something that would be safe and effective to use in patients. And so we're very proud to be part of that journey. The last thing I'll add to that answer is that there are a lot of devices that we've been involved with in the interventional space that can be thought of as Me Too products. So there's small iterations or small nuances where a device is adapted and made slightly better. And while that's extremely important, it's rare that we get to do something that's fundamentally new. And this is one of those things. I think Sarah Vask and the group of founders at Tufts Medical School in Boston really put together something that's never been done before. And there is tremendous buzz in our community about seeing if this can help people.
We work a lot with Sarah Vaskin, and I know there were a lot of doubters early on. So it's exciting to see that clinical trials are happening, and there's a trial right now called STRIDE. What can you tell us about the STRIDE trial?
So the stride, the way that, so these are all steps sort of in this process to having a device deemed to be safe and effective in the US. And the first step is to do a first in human. So that was done in Buenos Aires in terms of globally and at Yale New Haven in terms of here in the US. That data then gets packaged as part of what's called a pilot study. And the pilot study's purpose is to show that the device is safe, right? Because first and foremost, we don't want to hurt anybody. And that is then all submitted to the FDA, and they allow us then to move to the next step, which is called a pivotal study. And that's what's called STRIDE, that pivotal study. And that's an effectiveness study. So it's not only going to show again that it's safe in a larger patient population, but it's also going to try to show that it's effective. And so what STRIDE does is that it takes patients, adults with normal pressure hydrocephalus, one of the types of adult onset hydrocephalus, and it will compare uh, standard ventriculoperitoneal shunting to placement of an eShunt using this endovascular route in a head-to-head comparison. And the trial design is what we call a non-inferiority design, meaning that the purpose of the trial is not to show that the device is necessarily a better treatment for hydrocephalus, but that it's as effective as a standard shunt, but does away with many of the complications like overshunting, like infection, like um, you know, an obstruction or needing mechanical dysfunction of the device. So we're very excited. The trial is opened globally. I happen to be the co-global PI with Pedro Lilic, who's the doctor who did it in Buenos Aires, and we already have, I think, almost 10 sites up and running across the United States, and we're really excited that it's the field has taken this on as a challenge and it's enrolling quickly.
Great, that's wonderful. And we will put the link up to how people can find out more about enrolling. And it is on our HA website as well.
It's
So you
wonderful.
mentioned normal pressure hydrocephalus, and those are really your target enrollees. They're adults, but they have this unique etiology of hydrocephalus. Why did you start with NPH for this device?
So there's probably two main reasons, and both are relatively pragmatic. Maybe three reasons. So the first is that when you're doing these types of device trials, especially a device that no physician has done before, right? It's a completely novel sort of treatment that you need the procedure to be elective, right? So it needs to be we need to be able to book the procedure just pragmatically because there's a clinical team that's going to come in and support the case. There's an expert physician that will come and proctor the case to make sure that everything is done safely and according to the highest standards for the trial's point of view. So NPH is what we would consider shunting for that condition, an elective procedure, right? So it could be done non-emergently. It's not crisis mode, and so that's an important thing. The next thing is that I think NPH has been very often neglected. I personally think it's very much underdiagnosed. I think that it has When I was a neurosurgical trainee a million years ago, you were almost taught to not like the condition when we were residents. And that's because it can be a challenging population and challenging to manage the shunts after they're placed. And and maybe not everyone has the right disposition to want to do that. Um, and I think because of that, in part, it was neglected. I think the other part is that referring neurologists wanted to see a cure. And I think that while a shunt isn't a cure for the majority of patients with NPH, it can make their lives significantly better. But because it's not curative, I think the neurologist had a bad taste in their mouth about subjecting patients to the potential risks of surgery. And these patients are often elderly with other comorbidities.
Mhm.
So we were thrilled to be able to bring this to a population that we thought was underserviced, that the more minimally invasive nature would potentially make the treatment available to more people, right? Neurologists would find it more palatable, patients would find it more palatable, and the lower complication profile would be attractive so that more people can get the help they need. That very much resonated with me in particular because we run a large NPH program at Yale. Um, and I think the third thing is that the other conditions that we were thinking about, which were subarachnoid hemorrhage-related hydrocephalus, which where you get bleeding in the brain, you have hydrocephalus as a result of bleeding, and children, the pediatric population. Um, maybe it's not the best play. We don't want to do the things for the first time, I think, if it can be helped in children. So just, I think that was part of that story. And then subarachnoid hemorrhage patients can be extremely sick. And so it'll be difficult to know whether or not a complication or an issue that arises is because of the device or because of the severity of the disease. And so that makes the trial messy. So that's a long answer, but I think that that is why that population was targeted, the NPH population.
It's an excellent answer. It really helps. And I was about to ask you about other etiologies, other age groups, and you mentioned hoping to do this in children. And I understand this is a very exciting day for this device in terms of research and a breakthrough designation for the eShunt. So tell us about that in children.
I mean, it's just completely great. So one of the limitations of the device is that you have to meet some pretty strict anatomical criteria for the eShunt to be placed safely. What I mean by that is that um, the anatomy at the skull base has to be favorable, right? The arteries have to be not in the pathway of the puncture. The vein that we navigate has to be large enough for the delivery device to work properly. There has to be no bony encasement in the region that's going to not allow for the needle that we use to penetrate the CSF pocket at the base of the skull. So because of all those reasons, it wasn't clear that we were going to be able to translate from NPH to other populations. And I think Peter Kahn in particular, he was the chair at the University of Texas in Galveston at UTMB, had a particular interest and desire to work with the docs that he works with at Texas Children's. And they actually looked at about 100 patients that have hydrocephalus and figured out that many patients over the age of 12, so pediatric patients, would be amenable, like their anatomy was suitable for implantation of eShunt. And that was the backbone on which the petition to the FDA for breakthrough designation was made and ultimately successful. So it's very exciting. It's a very important milestone for Ceravasc, and I think the broader use of eShunt in different hydrocephalic populations. There is a close cousin to hydrocephalus, idiopathic intracranial hypertension, that we
Mhm.
also think it's going to be very useful for.
Wow, that's so interesting. So one of the things that you talked about earlier on was about some of the challenges with shunts, and oftentimes someone will get a VP shunt and they'll have to have multiple revisions, and that's really hard on the patient. But one of the daily challenges for many of the individuals who have hydrocephalus and a VP shunt is over drainage. and headaches. And my understanding with the eShunt is that the overdrainage problem isn't an issue. So how does that work that that doesn't create the same issue?
It's a great question, and isn't that amazing? Right? Like,
It
yeah,
is, it is.
what a great advance. So I'm going to give you a storyline about how I think, and many of us think, is made and absorbed in our body. So when you can think of in the middle of our brains that we have a little machine that, and you can think of it as a drippy faucet that makes CSF at a constant rate. And there's very little that we have in medicine that can turn the faucet completely off, or in fact, that could make it go faster. It just sort of drips at this constant rate. And so we're entirely dependent on the outflow passageways, all right, the pipes that get the CSF out of the brain to control how much fluid we have in our heads, because our heads are a closed box, right? The skull is a closed box. If the CSF builds up, that's also going to lead to an increase in pressure, at
Mhm.
least pressure on the brain, if not pressure globally within the box, and you're going to have dysfunction. So where does the CSF go? We think that normally the CSF is reabsorbed into the venous system, and that the conduit for that to happen, the connection between the CSF system and the venous system, is the arachnoid granulation. There's controversy about whether it's that particular structure or others, but there's basically some conduit between the CSF pocket and the venous pocket. And it turns out that there's always a gradient, so that the pressure on the CSF side is always a little bit higher than the pressure on the venous side, which allows the fluid to be absorbed down its gradient. That's how it works normally. If you need a shunt, and let's say a ventriculoperitoneal shunt is placed, what you're doing is that you're putting a tube in the sink that has this drippy faucet sort of dripping into it, and then creating an artificial bypass to get it out of the head and into, for example, the belly commonly, into some space that will absorb the fluid naturally, because the absorption processes or getting it out of the head processes are dysfunctional. That's non-physiological bulk removal of CSF. And so you lose the advantage of the regulation of this gradient. And if the brain is very compliant, what can often happen is that as the CSF is siphoned off in that middle sink where the drippy faucet is, the brain will, it's too much, and the brain then pulls away from the skull because the ventricular space is collapsed. The sink gets smaller, and the brain
Mhm.
around the sink pulls in towards it and leaves these hygromas or subdurals or overshunting. That happens because it's non-physiological, non-gradient mediated bulk flow removal of
Mhm.
CSF. And because the eShunt is completely regulated by physiology, it's completely dependent on this gradient and just takes advantage. It's just creating a connection between the CSF pocket and the venous pocket, taking advantage of that normal physiological gradient. It, in theory, cannot allow for overshunting to occur. And in fact, that's what we see. And there have been about 100 cases worldwide. We've done, I think, 15 or so here at Yale. And we have never seen a case worldwide of overshunting in an eShunt population, which is, I think, in and of itself, a tremendous advance.
Absolutely. In terms of quality of life, it's hugely significant for this patient population. And again, I know a lot of people are excited to see your studies continue. I wanted to ask you something in a broader way around research, and some of the challenges with NIH funding and other sources of federal funding. So currently, the NIH and the Congressionally Directed Medical Research Program, which is a place where we get significant hydrocephalus funding, as well as some of the other institutions like AHRQ and those institutions that drive discovery science, are experiencing significant funding cuts in recent weeks. some incredible research is happening in non-invasive hydrocephalus treatments. We have a couple of different labs that are close to potentially demonstrating preventing hydrocephalus through drug therapies. Very exciting. As a scientist and a surgeon, can you speak to the importance of investing in biomedical research?
Yeah, absolutely. Yeah, it's tragic, honestly, what's happening right now. And I think you mentioned it, but the Department of Defense also funds a significant amount of hydrocephalus research, especially as it relates to technology. And um, yeah, I think there's no question that this type of defunding of research agencies, especially to um, um, not only companies, but so academics and companies that are putting in the work to in a rigorous way to lead to advancements in the field to help people, um, I think will have a lasting impact. I think even beyond the research itself, what it will dissuade is people going into research in the first place. These are smart people. They can do other things. They can make much more money in other endeavors, and that they've chosen because they feel obligated and they feel that this is their purpose to spend their time dedicated to help advance science that will ultimately help people. And to make that even more challenging for that particular population of individuals who think like that, I think will dissuade a number of people who are on the edge that would have had very significant scientific careers, but will go into other endeavors because it's just not possible to sustain a living. I think that's sad, right? I think it's sad not only for Americans. I'll say that I'm Canadian living in America. I have for the last 12 years. But one of the reasons that I came to the US is that it's hard for, I think, people in the US to appreciate um, um, the that when they say that, the sky is the limit, that the sky is the limit in the US. That is not the case in much of the other parts of the world, including places like Canada and Europe, where you think of as very sophisticated, perhaps. But I think that the system that exists currently in the US is particularly special. Like it or not, the US is a leader in biomedical research, and I think that that jeopardizes that continuation into the future, which is really sad.
Yeah. Well, we're doing everything we can on our advocacy team to have our constituents talk to their members of Congress about the need to continue to fund these important research programs. So thank you for your explanation again about why it's so important that our federal government funds some of these programs. So thank you very much for spending some time with me today. It's been wonderful to hear you describe the benefits of the eShunt. Is there anything I didn't ask you that you wish I had?
No, just that really, I think the work that you're doing with the organization is outstanding. The organization itself is outstanding, and we are with you, and we hope that, and we are with the people that you represent. And the reason that we are doing it is that their lives can be, better, and we're happy to be part of that journey with you guys.
Thank you so much.